Hi, everybody. Good morning. I'm Yehuda Bassok from Global Health Supply Chain in the organizing committee, and it's a great honor to welcome you to the webinar, which is one of a series of webinars that we organize together with Cremonix and with Global Health Supply Chain. This is the fourth webinar that we provide. We aim to provide a webinar on relevant and important topics this year once a month and engage the community in constructive and continuous activities discussion. Today we spend time in discussing the important topic of managing the demand for vaccines, or more specifically, the issue of hesitancy. It is clearly an important issue now, and it will be an important issue in the future. This is not unfortunately, it's not the last pandemic, and the issue of hesitancy is to stay with us. Thank you.
Good morning, good evening, and good night to everyone. My name is Noel Watson. I'm one of the moderators for this webinar. I'd like to introduce my co-moderator, Baz Semo. She'll say a bit about herself, then I'll come back, say a bit about myself, do a little housekeeping, and then we'll get into our webinar. Baz?
Good morning, good afternoon, and good evening. My name is Baz Semo, and I'm the Managing Director of Global Health Programs at Cremonix International. Cremonix is a multi-sectoral international development company with 5,000 employees and a global presence in over 75 countries around the world. In the Global Health Office, we manage a wide variety of programs, including USAID's flagship Human Resources for Health in 2030 program, as well as the USAID Global Health Supply Chain Program Procurement and Supply Chain Management Project. We also provide technical assistance to USAID-funded bilateral projects, focusing on HIV/AIDS, tuberculosis, and malaria, and work to advance universal health coverage through private sector engagement. As a medical doctor with over 30 years of experience and global health experience in 20 countries, working in the areas of infectious diseases and health system strengthening, I have seen firsthand how infectious diseases and global health threats can impact human lives. Now, more than ever, as the global community faces its biggest threat yet, achieving herd immunity against COVID-19 depends not only on supply of the vaccine, but also on demand. Today, to discuss this topic on securing demand for COVID-19 vaccinations in low and middle income countries, we will be talking to an esteemed group of international panelists who are involved in addressing vaccine hesitancy. Our 5 panelists are Dr. Katherine Bliss, Senior Fellow, Global Health Policy Center for Strategic and International Studies here in Washington, D.C. The Reverend Dr. David Oginde, former presiding bishop, Christ is the Answer Ministries, Chancellor of Pan-African Christian University from Nairobi, Kenya. Please, can you put your camera on, Reverend Dr. David Oginde? Ms. Lolem Gong, Chief of Staff, Amref Health Africa, also from Nairobi, Kenya. Dr. Laxmikant Palo, CEO of People to People Health Foundation from New Delhi, India. And Dr. John Oladejo, Director of Health Emergency Preparedness and Response, Nigeria Center for Disease Control from Abuja, Nigeria. I'm looking forward to our discussion with the panelists on how we can best overcome vaccine hesitancy together by scaling up innovative and effective approaches. I'd like to hand it over to Noel Watson to discuss some housekeeping issues. Thank you.
Thanks, Baz, and thank you to our panelists for agreeing to be a part of this important discussion. So I'm a supply chain researcher in global health and a member of the organizing committee of the Global Health Supply Chain Summit. I also hail from Jamaica. It's a small but well-known island in the Caribbean. So the issue at hand has personal interest for me. Now, our approach in today's panel is that Baz and I will take turns posing to the individual panelists questions specific to their expertise and experiences. About halfway through, we'll take questions from you, the attendees, via the chat mechanism, and also do so again at the end. In addition, we ask registrants through an optional survey to provide their thoughts and questions on today's topics, and we have shared those with the panelists to help inform the conversation today. So the issue at hand, right? In order to reach herd immunity against COVID-19, scientific estimates are that we need anywhere from 60 to 80% of the community to be vaccinated. Today's topic looks at securing the demand for such vaccinations. The title deliberately turns the attention away from vaccines, what could be described as a supply issue and covered in a previous webinar, to instead focus on vaccinations and what could be considered a demand issue. One reason for this is that there is great variability across countries and within countries with respect to the acceptance rate for such a vaccine. One meta study, which looked at 30 survey studies across 33 different countries, they found rates of over 90% among adults in countries like Ecuador, Malaysia, Indonesia, and China. And then on the other hand, found lowest COVID-19 acceptance rates in Kuwait with 23.6%, Jordan with 28.4%, Italy 53.7%, Russia 55%, Poland 56%, the US 57%. And even among healthcare workers, doctors and nurses, vaccine acceptance rate also vary, ranging from 28% in Democratic Republic of Congo to 78% in Israel. And if we define hesitancy in terms of accepting the vaccine if it is available, we also recognize that having local access or convenient access to the vaccine will also impact the demand for vaccinations, and that these concepts of hesitancy and convenience are interrelated. So in our webinar today, we want to discuss both concepts, especially as they relate to the notions of community and the immunization systems and broader societal and extra-societal systems that communicate and interact with that community. And so we want to start off with Ms. Gong. Ms. Gong, you've been involved in global health for over 15 years now, including time at PEPFAR and Gavi, and now you're Chief of Staff at AMREF International, which has a presence in multiple African countries, and you yourself have been involved in the effort to address COVID-19, including progress with respect to vaccination. How do you make sense of vaccine hesitancy from your particular vantage point in Kenya, but also in other African countries?
Thank you, Noel, and thank you, Baz, for having us today, having AMREF speak on this platform, and really looking forward to the conversations we'll have today. So of course, across the African continent, as we've seen, we're beginning to see a trickle of vaccines. And I say a trickling of vaccines because to date, we've only vaccinated 8.3 million people. This represents less than 1% of Africa's 1.2 billion population. And if you compare that with other regions across the world, we are significantly behind in reaching a goal of 60%. Of course, the hope has been that we will at least get to 20% of a vaccinated population, but we're still so far away from that. And so we not only have to think about, and I think this is where we're lagging behind as well in vaccination, is that there was so much focus on getting the vaccine to the ports across the continent. And we did not really put as much effort into vaccination, right? So all the different health system factors that are needed, what we need, our communities to show up and be vaccinated, ensuring that we do carry out our duty as public health experts to ensure demand generation, getting vaccines administered. So when we talk about, and we've been talking a lot about vaccine equity, we do have to discuss, demand generation, and of which we know vaccine hesitancy is a major challenge. So there've been several studies that have gone on that have been conducted across the continent. One of the most recent ones is by the Africa Centers for Disease Control and Prevention, looking at vaccine hesitancy. And when I think of the results or the outcomes from these studies, hesitancy really stems from, several factors. Maybe I'll just pick out 3 to 5 of them. So one, trust issues, whether it's in the person who's administering the vaccine or in the system, in the institution, in the government. When governments are not transparent, when governments are not communicating on vaccine schedule, why is this person eligible and not this other person? What does a phased vaccine program look like? And why do we need a phased vaccine program for COVID-19? When that is not explained, it builds, this lack of trust, because I don't understand why my neighbor is getting the vaccine and I'm not getting the vaccine.
Who is he?
Right? So, who exactly? Who is he? Who does he know?
Who does he know?
And so so it builds this tension even within communities. One of the second reasons is also the perception of risk. What is this vaccine you're giving me? Why did we develop the vaccine so quickly? Right? When we look at the average time of vaccine development, we look at that 5-year period. Some take even longer. If we look at HIV has taken, we're still going on. So, but we're not explaining to communities, what are the phases for vaccine development, and giving that assurance that by the time you get the jab, this vaccine has gone through a thorough approval process. And so that perception of risk still stays there, right? Which is, of course, linked to vaccine safety. And then issues of beliefs and values, whether they're social, cultural, or religious. So it's great to see the good Reverend on this panel, and maybe he'll be able to shed some light on that.
We're going to go to him right out. We're going to go to him right after you, actually. So this is a good segue.
Great. Sorry, Reverend. But we do have to figure out what those issues are, because these issues contribute to vaccine hesitancy. And then just general lack of knowledge. When we looked at the study specifically from Africa CDC, we saw that, in a very small sample size, there were only 15 countries. It was great to see that in some places, such as Ethiopia, Tunisia, Niger, you had a readiness to vaccinate, I would say, of about 85, 90%. But then you see huge countries like DRC, Senegal, you quoted DRC in your intro, with very, the percentage is just dismal. We shouldn't have that level of hesitancy in a country with such a high number of persons. And so while some people believe that the vaccine is important, like I said before, a major concern is around safety. This is one of the main reasons that people cite for not taking the vaccines. And we've seen with the COVID, sorry, go ahead, Noel.
I was in the interest of time going to push us on to it, because I wanted Dr. Oginde to respond, especially along that line of beliefs, if I could.
Sure.
So Reverend Dr. Oginde, if you could turn your camera on so we can see you. You are the presiding bishop for one of the largest churches in Kenya. And now you work with associations of pastors in Kenya and other countries as well. What are you hearing and seeing from and within the communities with which you interact, and how do you make sense of vaccine hesitancy?
Thank you very much. I think the key drivers of hesitancy among particularly the faith communities and across actually the whole society, particularly here in Kenya, are very much similar to what Olem has talked about, the whole issue of trust, the issue of safety, the risks involved, and then of course the conspiracy theories. So we find, first of all, when the vaccine idea came up, there were many contradictory messages from global leaders. I'm sure you're aware of various global leaders who came up and were saying some people are conspiring to develop vaccines, and it's going to do this and that. When they come out, don't take them. And these are respected global leaders. And so this doubt that was put out there right from the beginning, even before the vaccines were prepared. There were people who were saying you need at least 7 to 9 years to develop vaccines. Then there's the whole issue, therefore, of uncertainty about the safety and the efficacy that has been brought also by global medical professionals who have come out and told us that these vaccines are still on trial stage. We do not know exactly what is going to happen. You know, nobody is certain about the eventual outcome. So people feel like, whereas this thing is being rolled out, we are being treated like guinea pigs on whom these vaccines are being tested. And nobody really wants to go out there and find they're the ones with a long tail after vaccination, and it will be too late. Then there is negative messages from key local and medical practitioners. Right here in Kenya, a very respected group of medical doctors under the Catholic Church came out and openly discouraged people from going for vaccination. They said there's a conspiracy behind this. There are pharmaceutical companies that want to make big money. There are people who are out to reduce the population of the world, and Africa is targeted. And these are medical doctors that we have trusted, and from a religious community that is very well respected in the nation. The Catholic Church does not just speak. When they talk, you know they are saying something. So when they come under association of Catholic doctors, then people take them seriously, and that just increases the hesitancy. Thankfully, the church leadership from the Catholic Church came out and disowned that position and said there's no problem with the vaccination, and encourage people to go ahead. But doubt had already been created. But number 4 is really conspiracy theories. This has been the biggest one, that there's the objectives of this vaccination are not known to anyone, but people who are in the know are that actually the vaccination is targeted at Africa. The population is going to be reduced. And so even the vaccines that are being given in Europe and in America and other parts of the world are very different from those ones that are coming to Africa. These ones are specifically meant to reduce our numbers. And so that really affects how people respond to this. From a religious perspective, the Christians in particular, this is the mark of the beast, that the vaccines are coming with a chip that is going to be installed in you and will be used to trace you, and eventually you will not be able to buy or sell unless you have a vaccine. And then more recently, you know that there's been talk about the vaccine digital passport, and everybody is like, here it is, exactly what we feared is right here. Now you can't travel, you can't buy. In some of the country, I can't remember which country, where they were saying you will not be allowed into restaurants unless you have your vaccination passport. And all these things are adding together really to make it very difficult to encourage or get people to the place where they can get vaccination.
Thank you, Reverend Doctor. So you're referring to the global messaging, local messaging, and then also this issue of local ideas that can be sort of catalyzed into these conspiracy theories. Thanks a lot for sharing that. I'm going to turn over to Baz, who will follow on with other panelists.
Thank you, Noel. Very interesting insights from the African continent. We now move to Asia. Dr. Palo, your work at People to People Health Foundation includes training health workers to address COVID-19 in India. In addition to this, you've also spent time in Southeast Asia supporting projects. What are we learning about COVID-19 vaccine hesitancy in this region?
Thank you, Baz. This is very important, and the issues that what we are hearing from Africa, similar issues in Asia and Southeast Asia particularly. If you see the India, it's a vaccine powerhouse. 60% of the global vaccines are made in India. Almost 6 or 7 half a dozen major manufacturers are in India. But if you see the response rate to vaccine in the community is almost 3%. So far, if we see the everyday the number is changing, but almost 50 million doses have been given so far. If I see the today's some addition of the number also. So India is targeting to reach 300 million doses, which is 1/5 of the population of the 1.35 population by August. So it's little slow progress, and that is same case in many of the other Asian countries, except probably Russia and China. But all other Southeast Asia countries where the vaccine access to vaccine availability is not still an issue, even though many of the countries are accelerating the rollout of AstraZeneca vaccine, but still there are challenges. If you see the Indian scenario, the slow uptake of vaccine, it started with the health workers. When we started the first phase of rollout of the program with the health worker, after 1 month of the rollout in India, only almost 1 of 10 people took vaccine, which is very low. The vaccine sentiment is really anti-vaccine sentiment. It's very greatly impacting the disease dynamics today, especially the fear, uncertainty, and doubt about the vaccine, and that is the same case in across Southeast Asia countries. And people are waiting. The second hesitancy is more people are still waiting to see maybe what kind of reaction is happening. Those who have already taken the vaccine, so they are little still observing and getting more input. Sometimes the credible source of information is also big challenge. And a perceived benefit, the perceived risk, of side effect. Like there are two category of risk factors. One is like in India, like two vaccines are Covishield and Covaxin are officially approved on the emergency approval. So inadequate trial also sometimes gives some kind of risk perception among the population, and sometimes even the people with comorbidity also are fearful about the vaccine. This might deteriorate the condition of their health, especially like the diabetes, hypertension people. They are still thinking whether they will go for the vaccination or not. The other the across all nations, if you see the mis and disinformation and rumors about the vaccine hesitancy, it's there. The one of the other dynamic, some of the democratic country where there are several political parties, the public trust in COVID vaccine and political environment is very important. So sometimes the inclusive approach to strategically position the vaccine before it kind of go to the public is very critical. More consensus, endorsement by scientists and doctors and the political parties, is very critical. And so that there is more consistency in what they are, the message, the kind of going from different channels and sources. And what could be a more missing point I see is community preparedness for vaccination. While we are busy in having the access to vaccine, and access to vaccine, probably we missed the how to prepare the community, that part. I think those are the critical, which has created a lot of confusion, a lot of kind of misinformation. Kind of, even though we'll talk about how countries are responding to those kind of challenges, but these are some of the things kind of we have seen, and some of the studies and evidence are coming also around these areas. Thank you.
Thank you so much. I think we'd like to hear about how countries are responding a little later. I want to move on to Dr. Bliss right now. Dr. Bliss, this issue of importation of vaccine hesitancy is being raised in several places right now. Your research has looked at vaccine hesitancy initially in the United States and increasingly in low and middle income countries. For example, Brazil. Can you please elaborate on your findings regarding this concept?
Sure, and thank you very much. And I want to say at the outset that it's raining where I am, and I'm right under a skylight, so I hope you can hear me okay. So at the Global Health Policy Center at CSIS, which is the Center for Strategic and International Studies, we've been focused on the challenge of vaccine hesitancy, both domestically and globally, for several years. And this is largely through our work in health security. And last July in 2020, we launched, in partnership with the London School of Hygiene and Tropical Medicine's Vaccine Confidence Project, a high-level panel on vaccine confidence and misinformation. And this concept was really originally developed in response to the global measles outbreak in 2018, much of which was connected to declining immunization coverage in the US and other countries where outbreaks were reported. But the panel's work was intended to focus attention on declining levels of vaccine confidence in the US and the role of misinformation, much of it amplified through digital media, in contributing to lower rates of coverage. And so, of course, as the project got underway in the spring of 2020, it was shortly after the WHO had declared COVID-19 to be a pandemic, and we realized that public opinion polls showed a great deal of concern and hesitancy in the United States regarding COVID-19 vaccines currently in development. We saw that much of it was driven by concerns over the speed and pace of research and clinical trials. Now, the name of the federal project driving funding and research collaboration in the US was Operation Warp Speed. So that maybe didn't necessarily inspire confidence if you were worried about the pace and rate of research. But we also saw an intensification of misleading information about vaccines, and that was being transmitted internationally through Facebook, YouTube, WhatsApp, Snapchat, and other platforms. And so at the time, these digital media platforms weren't really exercising the capacity to monitor or do any kind of labeling or fact checking. And so these messages really traveled at warp speed themselves. So the high-level panel convened an international group of experts representing the fields of public health, social sciences, security studies, cybersecurity, artificial intelligence, and who had worked previously with local, state, and federal authorities to inform our work. And really looked at two questions, in what ways do vaccine hesitancy and misinformation impact national security in the US? And what are concrete feasible steps that the US government, Congress, social media, industry, advocates, and community leaders should take to stand behind America's health and security? And so I think this resonates very much with what other panelists have said. We find that there are 3 or 4 main narratives that drive vaccine, or themes that are driving vaccine hesitancy in the US, or that underpin it. Concerns about the safety of vaccines and that the real risks are not conveyed or well understood. Concerns about the motives of drug companies or the scientists who work for them, or any other organizations promoting vaccines. And this idea that profits are put above well-being, or that vaccines serve some kind of ulterior motive, whether population control or experimentation or just information gathering. And concerns over government or school or sports district mandates. Some of this linked to concerns about health, some of it linked to a broader rejection of government regulatory authorities in general, and sometimes linked to libertarian or other kinds of religious nationalistic approaches. So, these are not mutually exclusive, what we found, and there are other themes that you see woven throughout, that really underpin all of them. And these include mistrust of government because of personal or historical experiences of racism or abuse by the health sector. But you see that they often represent unease with or mistrust of authority, the corporate sector, and a sense that science, at least Western biomedicine, is elitist, remote, and untransparent. And so the panel found that while misinformation and disinformation, whether deliberate, that deliberate presentation of false information, travels by word of mouth and by traditional kind of legacy media like newspapers and radio, but the rise of digital communications and the fact that anyone can create and post news without an editor or fact checking, and then with a click share it with hundreds of thousands of people, drives a great deal of current hesitancy. And particularly during the COVID-19 crisis, people are very anxious and looking for information. Just recall, it's only been about 15 months since any of this was even, reported in the news. And so, people are looking for information wherever they can get it. And so it's very important to be able to get reliable and evidence-based information out there and to listen to and understand people's concerns. The social media companies have taken a number of steps to address the issues, from removing content deemed harmful or presenting disinformation, or deemed to have presented disinformation about COVID-19 and vaccines, to deplatforming groups that use social media to organize. And they can tweak their algorithms to not amplify or prioritize content just because it gets viewed or liked a lot. And so then one of the things we looked at was the deliberate spread of disinformation about Western produced vaccines, sometimes by foreign state media. And another issue that our group spent a lot of time looking at was the international travel of these messages. And we found that the roots are closely connected to trade, travel, and migration diasporas. And again, particularly during periods of lockdown when people haven't been able to travel or visit family overseas, they may have become even more reliant on social media platforms for connectivity. And so we've seen the circulation of messages that may have been rooted in the United States picked up and shared with friends and family overseas, acquiring their own residence there, and then sometimes coming back. And so with extensive ties between the United States and Mexico, Central America and the Caribbean, but also with countries in South America like Brazil and Colombia, these themes travel far and wide and gain a local currency of their own. But I think it's important to say that vaccine confidence challenges have their own history in Latin America. On the one hand, since the launch of national immunization programs in the 70s, the region has had a number of immunization firsts: elimination of polio regionally, of measles, congenital rubella, and generally very high levels of immunization coverage. But on the other hand, similar to some of what other panelists have described, a legacy of discrimination, in this case against Indigenous and Afro-descendant populations, including through health institutions, leaves some communities highly skeptical of government motives. And you see, and the extraordinarily harsh impact of COVID-19 on countries in the region has stirred frustration over government transparency and access to services as well. And I'll just end with two examples. So if you take Mexico, for example, the country has one of the higher fatality rates related to COVID in the world, and it's now introduced COVID-19 vaccines. But in interviews and polls, some of the autonomous indigenous communities, some of the poorest in the Republic, are rejecting the idea of vaccines altogether, saying government health authorities will not be allowed to enter villages. A Cambridge University poll recently showed that 22%, nearly 1/4 of people in Mexico, agreed with a statement that the pandemic is part of a plot to enforce global vaccination. Brazil, similarly, has had a very successful immunization program since the 1970s, with coverage very high, above 95% for childhood diseases for many years. It started to decline around 2016, leading to measles outbreaks, particularly in some of the more remote states like Roraima and Amazonas. A yellow fever outbreak in 2016 was associated with the intensification of social media messaging about the vaccine, one that Brazil manufactures, but tied with responses to the Zika outbreak from the year before and discussions about the Olympics and the World Cup and many other kind of messages resonating in there. The proliferation of messaging now connects to Lusophone communities in the US, Sub-Saharan Africa, and around the Indian Ocean as well. So just, to sum up, I think we really see a proliferation of themes and narratives propelled by digital media, but international networks, and then mediated by trade, travel, and migration, and taking on new forms as it reconnects with different groups around the world.
Thank you so much. Really, really interesting sites there on how social media is playing an important role in vaccine hesitancy and how this hesitancy is being imported from the West to some of the more poorer nations in the world. And it's impacting acceptance there. I'm going to move on to Dr. John Oladejo. Dr. Oladejo, you have extensive experience dealing with infectious diseases in Nigeria, such as polio, Ebola, and now COVID-19. You have seen vaccine hesitancy manifest across some of these diseases. How is the vaccine hesitancy that we're seeing with COVID-19 different, if it is, from what you had to deal with in the past with other diseases?
Thank you very much for this question. As a matter of fact, Nigeria, first of all, had the first COVID-19 case on February 27, 2020, and we had the second wave in December 2020. And as you know, vaccine development will actually mitigate the spread of the outbreak and reduce morbidity and mortality. But when we talk about vaccine hesitancies for Ebola, polio, and COVID-19, we really need to look at the disease risk perception versus other life issues, infections, through vaccination. Then for Ebola, is mainly, on the high side. That is, the disease risk perception was very, very high. And then for polio is moderate, but COVID-19, the vaccine development, they look at that is too fast. There's a new technology, so there's a conspiracy as mentioned by the Reverend, and the disease is not so fatal. So there's a sort of a long-standing government mistrust. So why the rush for COVID-19 vaccine? We have been living with Lassa fever for the past 50 years now, and nobody talks about vaccine. And this disease has been killing so many people. And initially, it was discovered in one state, that is Borno State, in 1969. Now we have it in about 15 states out of 36 states. And it has been there killing people day in, day out. There was no vaccine for it. Now we now have COVID-19, and then suddenly we have a vaccine. So there is a lot of mistrust on that. So these are the issues. Then when you look at the confidence in the vaccine, the type, the health system, and the authority, you see that it's very high when you talk about Ebola, equally with polio, but with COVID-19 is very, very low. Then when you look at misinformation and conspiracy theory, which I've just mentioned, so COVID-19 cannot survive in hot weather. That is what we believe in this part of the country. And we have other therapy that exists. So why should I be taking a vaccine? What are the benefits? So the main epidemics is very low compared with Ebola, which is mainly epidemic, high fatality, scary, and high stigmatization, because people will not want to have anything to do with somebody that have Ebola. But in case of COVID-19, people will still move around and do all the work, even when you tell them that there's a particular non-pharmaceutical intervention measures against it. They don't observe it, they don't take to the measures. And in polio, which is endemic, we just came out of it, eradicated last year. The low fatality, fewer cases, a lot of advocacy taking place, and it's only saving children. But they are not sure whether it is safe. This COVID-19 is actually saving children. There are a lot of agitation that if you take this vaccine, there's likely tendency for you to be infected. And that even when you take COVID-19 vaccines, it doesn't really mean that you cannot be infected again. So these are the issues which were actually coming up. And initially, polio were actually rightly rejected in the North, but with the efforts of government and partners, the national partners, were able to develop strategies around communication, and people were able to accept it. But when you look at what is happening in COVID-19, you realize that we have not really started that area. And in the last couple of days, when COVID-19 arrived, we were able to only vaccinate 3.3% of the target population. We're supposed to at least vaccinate 50%, but we were able to only vaccinate 3%. So it's very, very minute. So this, most of the information have to do with correct information. That's to do with the confidence in vaccine, have to do with safety, efficacy, quality, and it has to do with risk perception. And this cut across all the diseases we were having before. We were able to overcome this with a lot of advocacy, especially in the North, with our traditional rulers, with our influencers, and with people at the local level, community level. So this one has not been fully achieved for COVID-19. And that we, in our center, we're really working hard to ensure that all these things are done. So we equally look at convenience. For Ebola, there wasn't anything like e-registration, but we have actually introduced that one now for COVID-19 to ensure that people can access the website and then register for it. Then the viral origin for COVID-19 is unknown, and we believe it's something like a man-made. And so there's a religious pushback on the COVID-19 vaccines. And so when you look at all this in totality, so COVID-19 has not really gained a lot of access by the target population. But we continue to work on this. Our communication experts, our risk communication corporate corporation, they have been having some telephone interview with people for the reason why we're having vaccine hesitancy. So one of it is protect self from infection or disease. This is positive. And then we have 53%. Most people have safety concerns about these vaccines, and that's the reason why they were not really taking it. Then another point through our telephone polling, which was done on the 12th of February, was mistrust of government, and that's about 24%. Then the mistrust of vaccine itself, that people really want to make money out of it. That's the reason why they quickly push it out. It was not made, and then they're now using the opportunity to really correct themselves by bringing out vaccine. That is 22%. Then some people say they don't feel any need for it. That's 11%. Then will always be protection by God. Some people say, look, I don't need this vaccine. God is always protecting me. Don't come near me. So that one is about 7%. The efficacy and potency concern, some people still believe that it can affect their fertility and so on, or it's just another poison, for them to die quickly, 4%. Others which cannot be explained, 3%. The injection phobia, some people will say, oh, I hate injection. I don't like to go to the hospital. Anytime I go to the hospital and I see injection with doctors, I always run away. That's about 3%. There are some people who just, look, I don't have any reason for it. I'm not ready to explain anything to anybody. That's about 3%. So these are the major reasons why people were given for vaccine hesitancy. So the vaccine will allow me to live long and stay with my children. Those are the positive ones, and they are the ones that we were able to vaccinate. I heard on radio that it will protect and and end spread of vaccine, COVID-19 vaccines. Those are positive one, and about 60%. I will take so that me and my family members will be protected. That's about 5%. And us, the health workers, assure me of its safety, I will take it. And this is equally 6%. But people that believe it is recommended by authority, there are 19% that authority believe that if you take it, you're going to be all right. And then those that say that it protects me from being infected, about 53%. So, it's very dicey, but because of the fact that we're now on TV, radio, and we're using local, we call it town crier, but they're not saying that town announcers. These town announcers are really living with the community. They are not the ones that are now bringing out these informations, and they're going from one house to the other, telling them about the usefulness of these vaccines. I believe with time, we'll be able to improve on this. So I have to thank you for giving me this opportunity to talk with you.
Thank you, Dr. Oladejo, for sharing some of the data that is coming out of Nigeria with regard to COVID-19 vaccine hesitancy. What I learned from all the speakers who've spoken up to now is that it doesn't really matter where you are in the world. Most of the causes are pretty much similar for COVID-19 vaccine hesitancy. So thank you so much, Dr. Oladejo. Noel?
Thanks, Baz. So I know I had said that we would ask some questions in the middle, but most of the questions actually have to do with addressing vaccine hesitancy. And that was what we're going to focus on the second half of our webinar. So I'm going to hold those questions and just push ahead if the attendees will allow me. And Dr. Oladejo, I just wanted to continue with you. You started to mention some of the elements of the approach that's being taken in Nigeria to address vaccine hesitancy. I was wondering if you could,
yes,
if you could continue to talk specifically about those elements, and then also maybe not just vaccine hesitancy, but with respect to any health system barriers that may be impacting the demand for vaccination. Can you say something also around the elements of your approach in Nigeria that's addressing hesitancy, and that's also addressing any system barriers against demand for vaccines?
Thank you very much, Edmund. When you look at most of the reasons that were actually accrued for the vaccine hesitancy is the fact that some of them will say when they get to the hospital, they have to spend, that is time waiting, that is the waiting time is very long. So they will not attend to them in time. And this has to do with the number of staff or the number of health workers that are in that health center. So this is being addressed by government, and that is the reason why we have to bring in such capacity. We quickly train, we train more than 5,000 health workers and then deploy them to all these centers. So that is the major aspect. Another thing is, do we really have enough vaccine to really go around if we really want to do it? Yes, because immediately we were talking about procuring of vaccines, we quickly divided the deployment into 4. So the first quarter we are expecting 5,600,000 doses, and we are actually looking at healthcare worker frontline for ports, that is for air, land, and sea port. So we equally, deploy such capacity to those entry to, because we didn't have enough manpower there. So these are the impediments, which we are really looking at as government, and we have partners that are really helping us. We equally
Dr. Oladejo, you're breaking up.
looking at okay, so we are equally. I'm talking about AstraZeneca. We're talking about Johnson & Johnson, 18.4 million, and we're looking at local government with highest disease burden, so that we're able to really tackle that area. We want to reduce the mortality, which is very, very important. So we're looking at 18 years and above, and then we're equally looking at the healthcare worker. Because if the healthcare workers are well protected, it will be easier for us to be able to reach other group or other target group. So the middle issue is manpower, which we're really solving now.
Follow-up question. One of the issues that's come up, both been raised by other panelists, it was raised when we did a survey of registrants, is this issue of safety. What are you doing specifically to put out the message about the safety of vaccines? Are there any specific efforts, whether social media or what have you, with respect to safety of vaccines that you have planned for Nigeria?
Technical working group on safety. So the major thing they are doing is to ensure that the people that have been vaccinated, in calling them on phone, to be able to know whether there's any effects after following immunization. So we have not really vaccinated so many. We have only vaccinated 122,000 vaccinated now, and we hope to really, that is 3.1%, we really hope to go to about 50%, so that we'll be able to really come out on this to know what are the issues. And then we prepare this committee to take care of any adverse effects following immunization with immediate effect. So we have a very good strategy, we have a very good program to really deal with that. Then from the point of manufacturer to the point of we ensure that the vaccine maintains its potency, because this group of people too, they monitor the vaccine from where it is being manufactured to the exact point where it is being utilized. So we have a very good strategy for that. We have a group of technical working group that are working on this.
Excellent. Thank you, Dr. Oladejo. Let me pass it on now to Dr. Palo. Dr. Palo, a similar question to you. What are some of the key elements of the approach in India to address vaccine hesitancy and any health system barriers against demand for vaccination? And if I could, what elements are you optimistic about and what elements concern you that they may not be sufficient?
Okay, thank you, Noel. And you know that India has started the world's largest immunization exercise for COVID-19 by Prime Minister Mr. Modi on 16th January 2021. And also at the same time, India also planned to donate or sold more than 60 million vaccine doses to 76 countries. So it's a two-way. One is responding to own need, also responding to the others, kind of other countries, kind of. So in India, two vaccines, kind of Covishield, which is a AstraZeneca, Oxford AstraZeneca, then the Covaxin, which is more kind of homegrown, kind of government-backed vaccine. Both efficacy is almost 81%, kind of. They've started rolling out, and India is one of the, again, runs the world's, one of the oldest and biggest universal immunization program, and also the pulse polio program. These are the two programs which India has good understanding and kind of a plan, which is a very regular program, kind of. So that is the experience India really used to develop a strategy. And initially, a dry run was carried out over 3,000 centers across the country. Then the first phase of the vaccination drives launched for the health workers. So and the frontline health workers, especially those in the essential services like policemen, housekeeping, kind of, and in the private sector also, kind of, both government and private sector. So including and eventually last 10 days earlier also, initial the program was started with the government facility, as the kind of vaccination center, but eventually they include, because India has a bigger private sector kind of facilities, hospital and clinics, so they added the private sector hospitals also, which with a nominal fee of say $4, kind of, if somebody goes to private sector, but if they go for a government facility, they will get free of cost, kind of. So private sector charges per dose $4, and government is free. So the current phase, kind of when they started the 60 plus population and also 45 with comorbidity, kind of, that is the initial round. But just yesterday, government announced that any person above 45 years, they can also go for vaccination without comorbidity. So that is increasing the kind of number. So from 1st April, the 45 years and above can get the vaccination. And at the same time, what government started, because its a number is so huge, so there are two applications which are very popular and people are using also. Co-Win, it's a registration platform, and also the Arogya Setu, another kind of to track the COVID kind of cases, that has been also used for the registration, follow-up and tracking of the vaccination. So once first dose is given, the next dose, then the tracking is happening. The political leadership openly come out in public and social media, showing their own vaccination, encouraging others to go for minimize the fear and go for vaccination. That's a good kind of strategy India adopted, and very comprehensive communication strategy kind of was developed, and through all possible channels kind of to reach the community. So even the health minister and others, they go and very periodic, very frequent meetings with the public and in the media, mainstream media. So that is another strategy, kind of is probably, it has shown that the trend of increased uptake of kind of the vaccination is happening, and doctors and key leaders are being made the champions. That's very credible, because the credible source of information is, as we all know, that is very important. They have played a very significant role driving the messages to build the trust in the community. As usual, the community engagement is very critical with credible communication approaches, targeting especially the traditionally known vaccine hesitant and resistant areas, and groups and or communities, best as a priority to target them, kind of, and orientation of credible influencer for local community to build their trust and acceptance, was one of the plans, kind of been implemented. Real-time, round-the-clock monitoring of digital media is very important, because we all have been discussing, and we know that digital media plays, kind of role more positive and negatively, kind of, So that is one of the kind of plan we see very effective, and as a part of that, National Media Rapid Response Cell was set up by government, which really tracks all those messages, rumors or misinformation, disinformation, all those kind of things, and also responding them to timely is very good move. So I see a couple of good things now, kind of the response to the vaccine was slow in the beginning, but the way that some of the dynamic apex level leadership in the country also coming up, and kind of showing good gesture of vaccinating themselves is a good move, and which is progressively kind of building the confidence of people to go for vaccination. So and also development of a co-win dashboard to monitor communication actions happening. So any person anytime can go and see a real-time data on the website how many people have been kind of vaccinated. All those kind of information are very some of the missing points what you kind of mentioned that could be we could have the community preparedness plan. We could have done maybe a more robust community preparedness plan for vaccination before kind of the vaccine launch, kind of and a two-way communication is very important, because many of those issues, unless there is a credible source to address that kind of one-on-one kind of it's going to be kind of very critical, because many of those messages going through mainstream media or social media, others, even if they are credible source, but the responding their specific concerns is very important. So more localized plan need to be there, kind of, so that the concerns, misconception can be addressed at the individual level. So that is more micro level planning, kind of more is needed, and looking at the cultural and other sensitivity around this, and improving the coverage by lowering the age of group of eligibility, because that already India started, but probably it needs more action, even other countries also. Improving the coverage, because we have seen that the response rate of younger generation, younger people are more than kind of the 60 and above. So I think that could be another strategy, but all depends on many of the vaccine availability and other factors need to be considered. Intensifying engagement of religious leader. This is kind of still we have done, probably we need to do more, so that kind of some of those hard to reach community groups or areas can be kind of reached, and so trust in COVID vaccine is vital to control the pandemic. Kind of those are kind of really essential. And now also we have to address the issue around the single dose and the two doses, like the new Johnson & Johnson kind of vaccine. So those people are also waiting, whether we'll wait for that. So we need to address those issues, and more at the micro level. And what is more essential is more trusted messengers, kind of more kind of different level of society, is very important. Thank you.
Thank you very much, Dr. Palo. Hand it back to Baz.
Thank you, Noel, and thank you, Dr. Palo. Ms. Ngong, you spoke earlier on today about the mistrust in government and institutions, and Dr. Bliss spoke about importation of misinformation and disinformation related to COVID-19 vaccines. How do we build trust with communities in the African continent and help them to move away from this misinformation and disinformation that's taking place with regard to COVID-19 vaccines?
Yeah, so I think there's several ways that we can do this, and we've seen this work in different settings across the continent. And maybe I'll just highlight two or three. The first one being really helping communities understand the vaccine development process. That's one, and a few of my fellow panelists have mentioned this. So educating communities, sensitizing our communities, so they understand the process of developing a vaccine, particularly with the COVID vaccine. One of the panelists mentioned that some of the areas of misperception was triggered or was fueled by how fast the COVID vaccine was developed. So it's really important that we are able to educate our communities on vaccine development. As we receive vaccines on our shores, we should already educate our communities on where they should get the vaccine. I mean, the example from India and also the example from Nigeria on being able to track vaccine, to register, know where to get a vaccine, understand the vaccine schedule, And I would even go as far as explaining vaccine efficacy. What's the difference between efficacy and effectiveness? Why, I mean, we've seen across social media the comparisons between AstraZeneca, Moderna, Johnson & Johnson, et cetera, and really helping our communities understand, those differences in efficacy and what it means for them. And then I think the most important part of working with our communities is using trusted sources of information. I was so glad to hear Dr. Palo mention, I think his last point was on trusted sources of information. So our healthcare workers, starting with that, particularly our community healthcare workers, because they know the community, they know the neighborhood, they know, who's sick, who's in need of help, etc. So how do we use our community health workers? Ethiopia, Rwanda have a really fantastic formalized community health worker community health workforce. How can we help? I think we need to look at how best to formalize that sector in other African countries. The other source of information are our community leaders. So whether this is priests, pastors, or whether these are our traditional healers. But, every community has this trusted person who kind of leads the community and galvanizes the community. So how do we use those community leaders to get the word out, to help educate the community? And as we know, there's a significant number of Africans who still trust in radio and listen primarily to radio. So how do we get messages through out using radio and not only social media? How do we involve community groups in getting on radio and getting on TV? I think these are just, some of the key ways in which we start building trust. And as you can see, a lot of that is focused on communication and transparency, and keeping that continuous dialogue with our communities. Thank you.
Great. I just have one follow-up question for you. Traditional media never seems to keep up with social media. Do you think it's important for these trusted communities to actually engage in social media so that they could change some of that narrative around vaccine hesitancy?
Sure. I mean, I think, it's yes and no. Yes, in the sense that I think, diversifying the communication outlets is extremely important. So it's important that we use all different, vehicles of communication. So yes, so radio, social media, or let me just say traditional media, social media, and so on. But then at the same time, I think we also need to think about, how do our communities consume information, right? Because as we know, the rural areas are not going to consume social media as fast as some of our urban areas. So it's using both, but maybe being a little bit more targeted. So if we know that in some areas, and there's so many studies on, forms of consumption. So if we know that in particular rural areas, TV and the newspaper is what people are most likely to turn to, then those should be used. In other areas, it might just be your community meetings even, then those should be used. But I think this is a time when we have to use our entire army of communication tools to ensure that communities are getting the information they need.
Great, thank you so much. Moving on to Dr. Bliss. Given your efforts in addressing vaccine hesitancy in the US and Latin America, which of the things that have been mentioned by your fellow panelists resonate with you? And also, what work is the US government doing in the global space with regard to mitigating vaccine hesitancy?
Well, thank you. I mean, as everyone has emphasized, making vaccines available is important, but access and delivery are really only part of the equation. And listening to people's concerns, questions, addressing their full range of concerns about vaccines, vaccine science, research and development, and all the questions about different COVID-19 vaccines and efficacy rates is important. but providing support for other health issues and those social challenges beyond the health sector, I think, is also essential. And we've heard this now, but through routine work or work on routine immunizations, as well as support of the global polio eradication initiative, one of the important lessons learned is that having a bunch of outsiders show up one day to offer a vaccine that they think is essential to global health security is not all that helpful. Communities really want a suite of health interventions, not just a vaccine for a disease they may or may not have seen in their area. And they want vaccines delivered, as everyone has emphasized, by people they know and trust at the local level. So the need to build the capacity of local implementers, is an incredibly important lesson. Encouraging greater support and activism by the most affected social and economic sectors is critical. And that's transportation, agriculture, and food services, education. And those leaders in those sectors need to speak early and often. And also really encouraging efforts by digital media to label posts if they present false information, to remove them if they are harmful, and to redirect people to credible health information. We've seen is really an important element of this, but I think we also have to do, the health sector needs to do a better job of making the accurate information as compelling and interesting as the misinformation that often gets liked and clicked and passed on very easily. Official communications can sometimes be a little bit dry or not as dramatic. So finding ways to help encourage that kind of communication is important. Now, the US government has supported global immunization programs bilaterally and multilaterally for several decades, has been a longstanding supporter of Gavi, the Vaccine Alliance, which focuses on procuring and distributing vaccines to at low cost for the world's lower and lower middle income countries. In the countries that have graduated from Gavi support since, over the last 10 or so years, as they've developed economically and moved from eligibility for Gavi assistance, the US government agencies have provided technical advice to those countries, helping them manage that transition and ensure sustained vaccine demand and become fully self-financing as well. Now, in support of Gavi's net new 2021-2025 work phase, the US has made a $290 million annual commitment to really support, the broad range of issues within that work plan, which include a very significant emphasis on vaccine demand and acceptance, which the Alliance has made part of its overall strategy of reaching the zero-dose children in particular, and also, just really ensuring mothers and other household decision makers are educated about vaccines and how they work and what information they need to make decisions for themselves and their families. Now, the United States also, I think through USAID and the Centers for Disease Control and Prevention, provides technical support to national and local level organizations in partner countries to ensure management and effective delivery of vaccines. And, in the last few years, Gavi, UNICEF, the WHO, and a host of other organizations have supported, launched and supported the Vaccination Demand Hub, which is really meant to carry out research about the behavioral and social drivers of vaccination demand and acceptance, and then also to test interventions to improve understanding about what works as far as helping people understand the benefits of immunizations, including dialogue with civil society groups. And the CDC has been an important part of those discussions. And then just finally, in December, the US Congress approved an allocation of $4 billion to Gavi, to support the COVAX facility, the international facility, to support its advanced market commitment to distribute COVID-19 vaccines to the 92 lower and lower middle income countries that are eligible for the AMC. And I think $2 billion is out the door. And so, vaccine confidence and trust are really essential components of the work that Gavi, WHO, UNICEF, and other global partners are doing with COVID-19 vaccines and routine immunizations. And as a member or donor, I think the US can support that work, can continue to share bilateral experiences and from the domestic experience with vaccine rollout as well.
Great, thank you. I'm going to pass it on to Noel.
Thanks, Baz. And Reverend Dr. Oginde, if I could, if there's anyone here who knows about trying to get a message, out to people who may find it difficult to accept, it's a pastor. So what insights, and if you could turn on your camera, Reverend Doctor, that'd be great. What insights from your own experience of changing people's hearts and minds would you emphasize? and maybe talk a bit about how you try to address COVID-19 vaccine hesitancy within your own communities.
Thank you. And thank you for that great compliment to pastors. It's very rare to get compliments as pastors.
Anytime.
Yes. Nothing very unique, though, from what the others have said. In communication, you know that for a message to go through, the first and most important is the who. Who is speaking, who is conveying the message, because that then draws the attention of the people. And so, like has been said before, credible voices are the most critical for changing hearts and minds. We need leaders who are trusted in society, not only by people who know them, but even people who have heard about them, so that when they speak, there's a sense in which if so-and-so believes that this is true, even though I have doubt myself, then there must be something about it that is worthy of listening to. From a church point of view, biblical teaching is very important, that we need to address the spiritual concerns of the people. I mentioned earlier that some of the hesitancies arise from the fear and suspicion that this could be part of what the Bible teaches about the end times. Mm-hmm. I personally took, when COVID-19, just at the beginning of the COVID-19, I took a 8-part series of sermons to just address the issue of end times, and particularly address the issue of the mark of the beast. And right, I remember that time.
You took this, or you gave this
seminar? I did. I gave not a seminar in church. I took 8 weeks, Sunday after Sunday, just teaching about the end times and what the Bible teaches, so that we do not associate COVID-19 and the possibly coming vaccine. That time there was no vaccine to be part of this end time thing. Just yesterday, when I was on Twitter, I found somebody had written there, because I had been on radio the previous day and we were talking about vaccines and the hesitancy. And I mentioned that there's no reason why people should be hesitant. So when I went to post something on Twitter, I found somebody had written there why I was accepting that people should take a vaccine. And I know that the Bible talks about these things in the last days. So I forwarded to them a message that had actually spoken during the series on the mark of the beast and what it actually means, how it works, and what it will mean, and how that relates to the current debate about vaccines. I gave her the link, and they went back and listened to the message, came back and said, now I understand. I can see the difference. I can appreciate what you are saying. So good objective teaching that addresses people's concern is very important. And this can be done also through community meetings, not just by pastors, but credible leaders that just give information that is understood by the people. One of the challenges that we are facing with the COVID-19 communication, official communication, is, like somebody has said, it's crass, it's dry, it's facts, it's figures. So many people have died, so many have been infected, but it doesn't address the heart. It doesn't address people's feelings. It doesn't address people's questions. So somebody needs to speak to that. We need to speak to the hearts of the people. We need to address the concerns of the people, the fears that people have. And when that is done, you find that it is so much easier to then turn people to actually realize that this is important, because people are concerned that their friends, their relatives, their families are dying out of COVID-19. On the other hand, they are afraid also of taking the vaccine. So how you bring a link between these is very important. On the issue of taking the vaccine, I think, is one of the most powerful ways of addressing this concern. We need these credible people, credible leaders to come out and publicly take the vaccine. And when people see David Oginde, our bishop, has taken the vaccine, then they feel perhaps this thing is not as bad, you know. If he dies, we will
don't cry. Don't cry when the needle goes in, okay?
Even if I cry, then they will say it seems painful, but at least he took it. So that is another way so that we can mobilize community leaders at various levels, like had been mentioned earlier, so that they can demonstrate that this thing is can be trusted. We can come out, we can take the vaccine. A friend of mine who I was talking to today took the vaccine, and he said, by the way, I don't have a tail, you know, I'm just still okay, you know. And we laughed about it. And another yesterday told me the only side effect I felt is hunger because I stayed on the line for so long. So this credible people making it easy to the people, I believe that we will overcome this hesitancy, because there's been so much confusion, particularly with the social media, but it needs to be countered with good information, but more specifically, speaking to the hearts of the people rather than just to the minds.
Excellent. Well said. Well said. Baz?
Thank you both. This final question is for all the panelists, so I want to ask you all to put your cameras on. I'm going to give you each 1 minute to tell us what your organization's role is in addressing vaccine hesitancy. And if your organization isn't currently doing anything in this area, what its role should be. So we'll start with Dr. Bliss.
So, you know, at CSIS, our work is very much focused on research and convening discussion and debate among policymakers to identify the kind of practical, actionable recommendations for the US Congress and the executive branch. And our mission, you know, is really to provide independent research and recommendations on US engagement with the world. So we'll be launching this report of the CSIS London School High Level Panel in early May, along with a series of short videos and podcasts on the topics of vaccine confidence, misinformation, and national security, kind of intended to reach a broader audience than just the policymaking sector. We'll be continuing our work analyzing US support for global immunization programs, including Gavi, CEPI, the Coalition for Epidemic Preparedness Innovations, and the Vaccination Demand Hub, you know, among others. And really, we see these issues of acceptance and demand, both domestically and globally, as intrinsically connected, and look forward to working with others to advance analysis and development of research about routine and COVID-19 vaccine access and acceptance.
Thank you, Dr. Bliss. Ms. Gong?
AMREF is very much deeply rooted in the community, and our focus has always been in strengthening community health systems. So for addressing vaccine hesitancy, or in addressing vaccine hesitancy, I would highlight maybe 3 areas. One is on really ensuring that our communities are prepared to get vaccinated. And so we sit on various national task forces across Africa, supporting different governments in doing exactly that, risk communication, working with community leaders, etc. Second is in conducting rapid research. And this is really to inform local and national government guidelines for COVID-19 vaccination. And then third, we have been playing a really active role in supporting regional bodies such as the Africa Centers for Disease Control and Prevention, as well as WHO Afro. And we've worked with them in various capacities, sitting on various strategic committees or technical working groups, steering committees in really formulating guidelines for member states. And then secondly, in a more active program implementation role, if you will, we've been training and deploying health workers, especially community health workers, in various African countries. Thank you.
Thank you so much. Dr. Palo?
Thank you. People to People Health Foundation is looking more kind of the operational level challenges, more at the community. We work with the national government and also the local government to address these issues, because the directives comes from national government, but operational challenges are more. So working with the community and local government and addressing those issues are one of the kind of action that we have been taking. So act locally, more kind of, that's what the our focus. And we also engage our partners through our alliance ASTA, which is Asia Africa Public Health Alliance. So we also do more micro level supply chain issue challenges at the community level. So what is more important for us to really focus is more continuously we need to demystify what's behind the fear of vaccines. That's very important. So a close look at the more social, cultural, and political issues that influences kind of immunization need to be continuously kind of understand and also respond kind of locally. That's where our focus, because unless we address that locally, things are not going to change. So, and more misinformation will come and that will continue. So we need to address timely locally, and what we also discuss about more trusted messengers like doctors, community, and religious leaders. So those are the kind of critical area for us. Thank you.
Thank you so much. Dr. Oladejo?
Thank you very much. As a matter of fact, we have been involved in the IEC material development. Our actual mandate is to protect, detect, diagnose, and treat any form of pandemic or epidemic. And so one of the things we are actually doing right now is to develop IEC materials. And these IEC materials are not just going to be at the TV or radio stations, they are even going to the local level with our town announcers, posting it and even giving out flyers. So we are engaging traditional rulers, we're engaging the philanthropists, the influencers, to ensure that this information gets to all the grassroots level to reduce vaccine hesitancy. So we now developed a strategy called TEACH, that is TEACH strategy, which has been launched after a national multi-sectoral WG was actually established to look at it. So the first thing is traditional vaccination campaign approach, electronic self-registration by eligible Nigerians. Then here is assisted electronic registration of eligible Nigerians, and C is concomitant vaccination alongside electronic registration. And then the last one is age, which was house-to-house electronic registration. So with this on our website and with the community involvement and mobilization, we believe we are going to reduce vaccine hesitancies in the country. Thank you very much.
Thank you so much. The Reverend Dr. Oginde?
Thank you. In the Evangelical Alliance of Kenya, we have embarked on civic education for our church leaders by inviting experts to give factual information on vaccine preparation, its deployment, and efficacy. And this was very, very useful because we invited professors in this area, in this field, to explain, for example, why the COVID-19 vaccine was developed within such a short time. And they explained that most of the research had been done previously and testings had been done because COVID-19, though it is new, its strains had been there before. So that gave people some confidence that actually it is not as short as seems to be. We are also addressing issues to do with fake news and conspiracy theories, like I said, by just helping people understand how some things happen. We have encouraged people to check information on fact-check websites, because there are such websites that are available where you can go and check a piece of information and they will give you whether it is true or not. And many of such websites are available that we have directed our people to just check information before they pass it on to others. We are also urging our leaders to lead by example by coming forward to take the vaccine. And that is already happening, and I think it is having good impact. So we believe that by and large, because we happen to be just at the beginning of the deployment of vaccination, I believe that we are going to have a better response as we go forward.
Thank you so much for that. Noel?
Yes, so looking at the time, it's 11:35. I know I promised a Q&A in the middle, and I promised a Q&A at the end, but I'm going to have to break those promises. Reverend Doctor, forgive me. So just to finish up, so today, after acknowledging the potential issues that vaccine hesitancy and convenience may have on our push to get to the other side of this pandemic, we shared perspectives on the drivers and potential solutions for these challenges. Our last question to the panelists touched on the notion of roles, and I believe that we all have roles to play across the different social aggregations as individuals, within families, communities, groups, countries, and so on. In dealing with vaccine hesitancy, I think it does start at the individual level. I think we must first acknowledge our own doubts and then seek out the information and the arguments that address those doubts, that set us free from them. And I think at that point, it makes us better advocates and contributors to the ongoing dialogue in the larger social circles that we inhabit. Our conversation today also reminds us that the fight that we have been in as a community, global health community, even before COVID-19, that of improving our country's health systems, ensuring access to as many as possible, as efficiently as possible, is a very good fight. That whether or not someone in a remote rural area gets healthcare can not only mean the world to them, but can mean the world to everyone else as well. Thank you again to our panelists. Thank you, Baz. Thank you, Yehuda. And to everyone, again, good afternoon, good evening, and good night.